Well, hello. Good afternoon already. Je ne parle pas de français. German, of course, it's very complicated for an Spaniard. So I will struggle with my English. I hope you will understand me. If there is anything that you miss, let me know, and I will try to rephrase it somehow, okay? Being the last in a panel like this brings some advantages and some disadvantages. So most of the ideas that I'm going to share with you have already been said. And to some extent, we are like the European version in an NHS environment of Kaiser Permanente in a much smaller scale. Kaiser Permanente is taking care of more than 11 members. We are taking care of 700,000. But well, we will see the similarities and I think it's very interesting to compare different environments, different systems, same solutions. Okay. Just as a short introduction, let me give you some ideas about Spain and our healthcare system for you to better understand what we are talking about. Spain is an NHS-based country like England. So we all Spaniards are entitled to receive public health care, free at point of delivery, and it's financed through taxes. Healthcare authority is in hands of the regions, and we have 17 autonomies or regions. Catalonia is one of those, but I'm not going to talk about Catalonia. Okay, and we are based in the region of Valencia. Valencia is the third largest city in the country after Madrid and Barcelona, and our region covers nearly 6.5 million people. Okay, the region is divided in terms of healthcare. The region is divided into healthcare systems, districts, each of those having one hospital and a number of primary care. Mental health is included under primary care as well. And similarly to Kaiser Permanente, we employ all of the professionals. GPs and specialists work for our company, one integrated management team, one single budget. Okay? That was not the case before, as we will see later. So we shifted from a fragmented environment into a one which is far more integrated. Does it make sense? Okay. So I will skip this because we are short of time. So everything we are going to see next is around these 4 key ideas. We are going to talk about the triple aim, which is commonplace, higher patient experience, better healthcare outcomes at a more affordable cost. And our model is around this PPP model, public-private partnership. Through this partnership collaboration, the private operator can bring innovation and flexibility into the traditional slow public system. So that allows the system to stop doing to start doing in a different way. We're going to talk about capitation. And this is very important. This is the main pillar, in my opinion, of our model. Capitation includes or means we take care of a cohort of patients, of a catchment area, of a predefined catchment area, and we are fully accountable of the global healthcare outcomes of that given population. I usually say that we used to be an accountable care organization even without knowing that we were an accountable care organization. Okay? So it's not that important the names, it's important what you do. Okay? Then healthcare integration. Healthcare integration, it's not a goal in itself. Healthcare integration is a tool for you to get to that point of delivering the best healthcare to the citizens that you serve. And then networking. Networking is one step beyond integration. Remember that those systems in the region, we are running 4 of those. We are not focusing on one individual, one single system, but we think of a wider network. So you can come up with more comprehensive solutions if you think of a wider population. Okay? Our journey. We got started in 1999 running a hospital on a stand-alone basis. Also with a capitated payment, but just the hospital on a stand-alone basis. At that moment, the region of Valencia was not under this integrated approach. We brought that integrated approach and was eventually later on was extended to the rest of the region after our experience. So we were somehow competing from the hospital with primary care, and it made no sense at all in a public environment to deliver public health care that way. So after 4 years, we managed to persuade the regional government so that they decided to include primary care within the contract. So I usually say that I was there at that moment, and we usually say that it's not that the hospital took over primary care. On the contrary, if someone took over someone, it was primary care taking over the hospital, and then we became a more integrated system. Okay? It was complicated because all these things we are talking about, it's about cultural change. It's about the professionals. It's about you guys. I mean, taking care of patients and thinking what's best for the citizens. So this is cultural change, and this is not a sprint. This is a marathon, and it's an ongoing process. It's an ongoing process. It will never, never finish. And today, since we are able to run a number of systems, we can think of something bigger. Synergies, shared services, shared professionals, networking, but not only from a local perspective. We can also think about going international. Technology allows for a wider perspective. Data-based institutions, enablers for, sharing data, sharing imaging services, sharing path lab services, things like that. So if you ask me what should be the main driver for this change to be successfully implemented, I would say that we need to think about what is best for the citizen. There is a global agreement about the how, about the what we want to change, what we want to achieve. But the problem comes when we need to think about how we are going to implement that change. And there is no one single answer for that, because healthcare is global for many things, but it becomes very local for many other things. So one size does not fit all. But if there is something at all that I would recommend, is to think about what is best for the citizen, keeping in mind the triple aim, and trying to identify everything that allows for a stronger alignment between the different stakeholders, and an alignment that allows for cultural transformation. On the bottom, you can see some of these tools, like integration, like processes, IT solutions, personalized care. You need definitely to align people around payment mechanisms. I mean, in my opinion, capitation is a very strong driver around the citizen needs, goals and incentives, reduce variation, etc. And that applies for all stakeholders across the patch. It's not only the responsibility of doctors or primary care doctors, hospital doctors. No, everybody has to be involved in this process of transformation. Community, policymakers, hospitals, primary care, mental health, everyone has to be aligned. How we do things? We do things around this triangle for success. I usually say that this is applied common sense. We are not reinventing the wheel. This is not rocket science at all. Okay? So this is about clinical management, people, and IT. Data. We are living the era of data. I sometimes don't understand why healthcare is so far behind. When we talk about the use of data compared to other industries like banking or car manufacturers, things like that, healthcare is so far behind. I don't understand why. So clinical management with a very strong focus on being proactive, because we usually say that when a citizen becomes a patient, it may be very late. We need to think about people, citizens, okay? And also a very strong focus on healthcare promotion and prevention. And that has a strong link with the capitation payment. We need to keep our citizens as healthy as possible. That's our main goal. People, human resources, We want to attract, develop, and retain talent. This is all about people, after all. This is all about people, after all, okay? And we have, for instance, introduced innovative payment schemes in the public sector in Spain. Our professionals, the ones who do more, and basically the ones who do better, get extra bonuses, and they get better paid compared to those working for the traditional public sector, okay? And our hospitals and systems are all university and teaching universities, hospitals and systems as well. And then technology. We were the first hospital in that moment, now integrated systems, developing our own in-house electronic medical record. It is fully integrated. It covers all the different functional areas, and it also interacts at primary and hospital levels. It also interacts with the financial ERP, with the workforce solution, with logistics, everything. So we are able to put all the information together in a big central data warehouse. So, and we are able to make an intensive use of that data for higher efficiency and for personalized care. This is your famous, worldwide famous Kaiser pyramid, okay? And here we are talking about, in this event, it's about DRGs and other tools. We, of course, use DRGs and CRGs as well to better understand the picture of the catchment area that we cover. We use all those tools to understand our patients' and citizens' clinical needs. And we have developed our own Kaiser pyramid. These are a number of different categories of morbidity, of complexity, of chronicity, whatever the name you want to use. And we have developed these categories in-house. It has been our own professionals, the ones working on this. And this is a very powerful tool for integration as well, because our professionals feel that this is their own work, and they understand very well what this is all about, okay? So, and we are also able to identify how many patients fall under each and every of those categories, and we can break it down to the level of individuals. And we know the cost per individual per year. And we know who is the GP responsible and the community nurse responsible for that patient, okay? Likewise, we can identify and we can plan on tailor care plans for each and every of those individuals. Okay? So you are familiar with this. In our systems, 27% of the patients represent 72% of the cost, but this is also commonplace in most systems, and I will give you some figures. Remember that in 2003 is when the integration came to one of our systems. Prior to that, the number of people freely going to the A&E department kept going up and up and up. After integration, we saw that the number of people going to the hospital started to decrease, and they went to the walk-in centers that we have at primary care level. We have satellite emergency centers in the systems that we cover. So we inform people about the waiting times, for instance, in the A&E department in the hospital, or the waiting time to be seen in a satellite urgent care center in the area, so they decide where to go. Those are quick wins that, they don't take much investment. It's just about, change the process and change the mindsets. Our waiting times are also far below those from the public sector and the community of Valencia and global NHS. So quality is also critical for us. Very, very, very important. It's part of our contract with the administration. We must take care of quality indicators or we can be penalized, okay? And when we talk about population health management and when we talk about capitation, chronic patients, for instance, are very, very important for us as well. So we come up with bespoke programs for them, and we put a very strong focus on identifying diabetes or identifying COPD or those non-communicable diseases and try to identify who those patients are and come up with solutions for them. Okay. Some figures, because I am out of time already. We are, and this is public figures, according to public figures, we are around 35% less costly per citizen per year than the average per citizen in the region of Valencia. Okay? Again, this is public figures. And we employ nearly 5,000 professionals, doctors and nurses, and we cover 700,000 people in the region. So some conclusions. Pressures on costs will continue to be a problem for healthcare systems all across the world, and we need to come up with innovative solutions. There is no one single answer, again, but some of these ideas around integration, capitation, one budget, alignment of professionals, reducing variation, all these ideas are part of the solution, definitely, because there is a huge healthcare tsunami coming. This is a global challenge, and we have the answers. We just need to think about how to implement those answers. Thank you.